Um, we're talking about genital herpes today, and we'll spend a little bit of time talking about the lookalikes because some things can fool us and look like herpes. And there we go. We're going to, by the end of this talk, hopefully have covered the fundamental virology and pathophysiology and pathogenesis of HSV. We won't spend a ton of time on this. We're going to spend more time on the clinical manifestations of HSV, particularly in the vulvar region. And we're going to be able to recognize different types of vulvar lesions, including those that may be infectious or non-infectious causes. And we'll have reviewed the current treatment options for genital herpes, including antiviral medications, and we'll discuss their efficacy and potential side effects. So genital herpes is very common. In fact, it's probably so common that its prevalence is a little bit challenging to determine. It can often be asymptomatic and it's not a reportable condition. So different jurisdictions have different means of estimating prevalence. In Canadian sero studies, we think that the seroprevalence of HSV1 is somewhere in this big range, somewhere between 1 in 5 to 1 in 2 people. And the seroprevalence for HSV2, a little bit lower, somewhere between 10% or 1 in 3 people. We know that HSV accounts for about 50% of genital ulcers that we see, although I would challenge that statistic to be pre-syphilis epidemic. It's very common that ulcers that I see these days are in fact syphilis. So a big theme, a big takeaway of this talk is, um, you know, really think of syphilis. If you're thinking herpes, think of syphilis. And in fact, they're so um, I, they're so frequently misdiagnosed that our CADM provincial lab has actually changed their workflow within, I guess, the past 2 or 3 years, that if you send a swab for detection of HSV, it'll automatically be run for detection of VZV and treponema as well, because they can mimic each other so much. So they get sent for DNA diagnosis of a variety of different viral and I guess spirochete uh, pathogens. So genital HSV, historically, we think of HSV2 causing genital HSV, but we now know that there's a significant proportion of genital HSV that is HSV1, and that shift has, in some reports, been seen predominantly in women, but the reports on that are variable. Genital herpes is transmitted by skin to skin contact, and that can be when somebody is symptomatic or when they're asymptomatic. And it can be genital to genital contact, it can be orogenital contact, or if there were HSV lesions elsewhere on the body, any type of contact with a lesion. We think that a big proportion of transmission does occur during asymptomatic shedding. And we know that having had exposure and infection with HSV1 does not cross protect from infection with HSV2. However, if you have one type of HSV and then you acquire an infection with the other type of HSV, typically when you are acquiring the second type, your symptoms might be less severe than a primary infection. Condoms can reduce the risk of transmission, but does not eliminate it. So that's an important nuance to have in discussions with our patient population about safe sex and protecting ourselves from sexually transmitted infections. And both HSV1 and HSV2 can be vertically transmitted from a pregnant person to their infant. So, why is HSV with us for life? Well, that's because it has a dormant phase in the sensory nerve ganglia. And so, following the initial infection, there is typically a latency period or an incubation period, I should say, of about 7 to 21 days. Following the primary infection, the virus resides within the sensory nerve ganglia and can remain intracellular and dormant for years and decades. Um, However, stressors, and that could include like lack of sleep, immunocompromise, comorbid infection, can stimulate the replication of the virus within the sensory nerve ganglia, and then it would travel down the nerve root, and it would express itself as a lesion at the dermatomal distribution of that sensory nerve ganglia. We know that after primary infection, typically our immune system kind of gains control of the virus and ushers it to sleep in the sensory nerve ganglion. And what these charts show, the thing to take away from these charts is that the longer you've had HSV, the uh, fewer days of the year are you asymptomatically shedding, the fewer days of the year are you having symptomatic lesions. However, it doesn't go down to zero. So clinical presentation can be very variable, and we certainly have many patients who present with with a recurrence without recognition or memory of anything that is described classically as a primary episode. So not only can clinical presentation be variable within one individual, but we know that there's a wide variety of clinical presentations between individuals as well. But kind of the classic that is described and that is not uncommon to see is a primary episode, which is the most severe episode for an individual typically. And that's because somebody has acquired the virus without any protective antibodies being present to either type of virus. You can have a non-primary first episode, and we're going to go over the characteristics of each. A non-primary first episode is when there is clinical evidence of herpes, and according to the person's experience, this is their first time having witnessed these symptoms. And typically, the symptoms will be less severe because there are pre-existing antibodies, typically to the heterologous type, but sometimes to the homologous type of HSV. And then recurrence is when there's a clinically evident episode and the individual recollects and recognizes and has experienced before other episodes that are like what they're experiencing right now. So the clinical presentation can be very variable, and I think um, a common criticism of modern Western medicine is that many of our texts tend to present uh, visual representations of disease pathology on sometimes very homogeneous populations. And so what I've tried to do here is present some diversity of both different stages of ulcers and vesicles and on different skin tones. So classically, the initial presentation is going to be that of a vesicle. So a cluster of vesicles on an erythematous base, which is um, classic for a lot of herpes viruses. And sometimes it can be difficult to distinguish, or I mean, without history from somebody, it can be challenging to distinguish between a primary and a non-primary and recurrent episode based on the lesions alone. That being said, there are certain characteristics that in healthy immunocompetent people are more kind of pathognomonic of a primary infection. So if you're seeing bilateral lesions, oftentimes that's a primary infection, although we should also be thinking of things like immunocompromise. And if an episode is extremely painful, needing IV medications for pain control, oftentimes we're seeing that in a primary presentation. It's important to know that those who are immunocompromised, so that includes people with immunocompromising conditions or those who are on immunocompromised immunosuppressing medications or neonates, may not only have bilateral lesions, but may have systemic illness. So may have symptoms of a systemic illness, may have symptoms that are consistent um, with encephalitis, may have symptoms of vesicles on a widespread distribution spreading across several dermatomes. So as we discussed, the first episode is typically more severe. It can be asymptomatic, or somebody can be profoundly symptomatic, requiring admission to hospital. So there's a lot of intra-individual variation, and we've talked about how immunocompromise would be one of the factors that leads to a more profound symptomatology. How long the lesions will last is variable, but it's fairly long, so it can last approximately three weeks if no treatment is applied. And because there is a fair bit of inflammation that accompanies the lesions, you can end up not only with the lesions themselves, but also with symptoms that are secondary to edema, like urinary retention and lymphadenopathy. In addition to having the dermatologic symptoms, often with the first episode, somebody can experience significant systemic symptoms, including fever, feeling unwell, sometimes a headache, and myalgia. And certainly, if somebody's presenting with headache or any other neurologic symptoms, it's important to think about whether they could be immunocompromised, whether you might be seeing encephalitis or meningitis. Recurrent episodes are, classically less severe, and there's still a lot of variation from individual to individual. They are very common in the first year following infection. So as high as 3/4 to 90% of people who have their first episode of HSV2 will have a recurrence within the first year, and the proportion is a little bit less for individuals that are primarily infected with HSV1. Classically, somebody can tell that they're going to have a recurrence. They experience prodromal symptoms, which they can describe as paresthesias, as burning, as tingling. And sometimes people will have systemic symptoms that occur as well. This is much less common than in a primary infection. And classically, the lesions are unilateral, but there are exceptions to every rule. And again, if you're seeing bilateral lesions, you're thinking about immunocompromised or immunosuppressing medications. Typically, recurrence lasts um, a little bit of a shorter window, so symptomatic for about a week and a half if treatment is not applied. In terms of testing for genital herpes, a question that oftentimes comes up in my clinic when I'm offering STI testing is requests to be screened for genital herpes. And there's really no role for routine serologic screening because so many of us have been infected with HSV. It's very common throughout the population. And just because you're serologically positive does not mean to say that you're going to be symptomatic. So I find that when people screen for HSV, it generates a lot of anxiety without much action that we can take. That being said, there are there are specific reasons where we do send serology, and that would be in a situation where someone becomes immunocompromised or perhaps is considering immunosuppressing medications. Or what presents itself to my office more commonly is serodiscordant couples, where there's a lot of anxiety in the couple about transmitting HSV, and they're identifying who's positive for which serotype does help to either alleviate that anxiety if they're seroconcordant, or help with some education and some strategizing if a couple is serodiscordant. And then we spend time talking about whether suppression of the seropositive partner is appropriate, or kind of instances to avoid risk of transmission. For instance, if somebody has symptoms of a prodrome or has active genital lesions. And the other time that we'll oftentimes screen, not necessarily with serology, but just screening with history, is if somebody is pregnant. And not only am I interested to know whether the pregnant person has had HSV in the past, because if they have, then I'm going to be talking to them about suppression in the third trimester. But I'm also interested to know whether the person's partner, if they continue to be sexually active with them, are positive, because then I'm thinking a little bit about what's the risk of the pregnant person getting primary HSV during pregnancy. So that would be another instance where I send for serologic testing. And if the pregnant person is susceptible and their partner is positive, we have some discussions about how to avoid contracting HSV during pregnancy. So how we diagnose HSV is through detection of the virus. The typical first line that we'll use is a nucleic acid amplification testing. So that's when you're going to send a swab, and you can send it in viral culture medium. And there is very excellent sensitivity. And the nice part about the NAT is that you it can detect particles of viral DNA, and the virus doesn't have to be alive. So you can deroof a vesicle, try to collect whatever DNA is there. And it's a sensitive test because it doesn't require live virus. You want to make sure that if there is a vesicle, you're removing the roof of it, you're getting to the base of the vesicle or the base of the ulcer. And if it's crusted over, I mean, don't not send a swab. You can send a swab, but beware, if it is negative, you want to keep in mind the evolution of the lesion at the time, because there's a higher chance that it would be a false negative. So a viral culture is another option. It's not typically first line, but it certainly is important when we're considering if there is resistance to antivirals. If you're thinking of sending a sample for viral culture, I would recommend calling Cadam Lab first to speak to a microbiologist to make sure that you're collecting the specimen in the right way, and especially since you'll be sending specimens down from the periphery, making sure that transport's going to be adequate, or else if there's a suboptimal viral culture that turns out to be negative, we have to say, well, was it really negative, or was there just something about the collection, transport, and culture which rendered the virus non-viable? And then type-specific serology can be helpful if you have a sample from before the lesions, and then what you're going to be looking for is seroconversion. So the nice part about our system here in Manitoba, specifically for pregnancy, is that we store the initial prenatal sample, and we store it for approximately 9 months to a year, so that throughout pregnancy, if there's any concerns, anything that pops up, we can call Cadam Lab, ask them to run the test on the initial stored sample, and we can look at seroconversion between the two samples. And that's particularly useful if somebody is diagnosed with herpes for the first time during pregnancy. So once we've diagnosed genital herpes, the question becomes, do we treat or not treat? And I think that there is a general sense among people in Manitoba that somewhere along the lines they've been told that treatment doesn't really change anything, so I don't really take treatment. And for many people that might be the case, but the WHO has really shifted its recommendations to consider treatment. It's not that you have to convince yourself to treat, it's that you have to convince yourself not to treat. And why would we treat when somebody's having either a primary episode or a recurrence? Because treatment accelerates healing, it prevents complications like post-herpetic neuralgia, and it reduces the psychological burden of either knowing that you have active lesions or having symptoms associated with them, and it can improve quality of life. It can give somebody the sense of empowerment that they can do something because this is a chronic lifelong condition. And in cases of, this shouldn't say prophylaxis, should say suppression, sorry, in cases where somebody is potentially at risk of transmitting to someone else, it can help to empower them to reduce that risk to their partner or to their developing fetus or the infant during delivery. So when we definitely want to treat is in first episode, we want to try initiate treatment before the lesions crest. In recurrent episodes, we want to try to initiate treatment in the prodromal stage, so before the lesions even show up. And in patients who have highly symptomatic episodes, we can offer them treatment episodically. Um, but in that case, we're also thinking about suppression, and we'll get to that in the next slide. Certainly, if somebody has disseminated disease or severe disease, including, and meningitis or encephalitis, then you would want to be treating. And neonatal disease definitely needs to be treated. And again, if there's lots of recurrences, especially of symptomatic episodes, consideration for suppressive treatment to improve quality of life. So there's lots and lots of reasons to offer either episodic or consideration for suppressive treatment for HSV. So the general treatment approach is first, am I going to use oral or IV medication or topical medication? Oh yeah, I've listed it here. And so severe disease requires IV. Most other issues will require oral preparations. While there is a role for topical acyclovir in oral labial lesions, there's really no role for topical acyclovir in genital lesions. So you're basically making the decision when it comes to genital herpes of, is this severe enough to require IV? If not, I'm going to reach for something oral. Again, you want to try to start the antiviral as soon as you can. So ideally in a recurrence during the prodromal stage or in a primary infection before the crusting happens. And that's because application of the treatment early will actually change the course of disease or the length of being symptomatic. If you start it too late, then it won't change the disease course. And in addition, like we think of antivirals as being the mainstay, and they are the mainstay of treatment, but they're not, when we talk about treatment in general, we want to talk about the ancillary treatments we can offer as well. So genital lesions, as particularly in a primary episode, can be very painful. So we want to think about offering appropriate analgesia. Particularly in a first episode, there can be lots of swelling, or even because of the pain, there can be challenges with defecation or with micturition. And it's not uncommon that when somebody is admitted for a primary episode of genital HSV on our wards, they can require catheterization because voiding is just too painful. And so laxatives, if somebody is having issues with constipation or even spasticity secondary to the lesions. There are lots of options of how to dose antivirals, and my suggestion is to choose one regimen for primary, one regimen for recurrent. And while our Canadian guidelines suggest different dosing for pregnancy, the reality is that many other jurisdictions, including the WHO, uh, don't don't distinguish between pregnant and non-pregnant. So another option is to consider using the same dosing regimen for pregnant and non-pregnant. So then you only have to remember one regimen for primary and one regimen for recurrent. I tend to use valacyclovir for both primary and recurrent, and we're going to look at a pricing guide in a few slides to underscore why I reach for valacyclovir, and it ends up being the most cost effective. The important, again, point is just the importance of prompt initiation. So if somebody is not going to be on suppressive therapy and they want to use episodic therapy, providing them a prescription that they can go fill ad lib so that they don't need to get into the office to get a new prescription would be appropriate. In terms of suppression for those who have recurrence, so again, we're thinking about people who have frequent episodes or who have very severe episodes, and that's not for us to decide if it's severe, it's for them to decide if it's severe, if it's causing them distress. If they are in a situation where they might be transmitting the infection to other parties, so if there's multiple sexual partners that are being exposed, or in serodiscordant couples, where they want to reduce the risk of transmission to the seronegative partner, those would all be good reasons for suppression. Basically, somebody tells you their quality of life would be better if they're on suppression, then it's a good enough reason. We want to reassess annually. We know that over time, our immune system tends to, um, providing there's no additional stresses to the immune system, tends to be able to suppress the virus. And we do see the days with shedding and the number of episodes per year becoming reduced year after year after year. So I tend to reassess how the person is feeling on their suppression, whether they want to continue with it annually. And we want to make sure that they're on a medication regimen that they can afford and access. Um, so I've indicated some medical reasons for suppression here as well. So in pregnancy, you're going to want to start at 36 weeks for somebody who we're anticipating a term delivery in, because what you're really trying to do is prevent an ulcer or a genital lesion at the time of delivery. If somebody has a reason to deliver early, so they have a history of preterm birth, or they have a history of preeclampsia, or they're pregnant with, I don't know, with twins, for instance, anybody that might have a delivery earlier, you are welcome to start the suppression earlier as well. And certainly if somebody has been on suppression, um, outside of pregnancy, I wouldn't discontinue that suppression just to start it again at 36 weeks. They can continue throughout pregnancy. For those with HIV with a CD4 count less than 250, or those who are on chemotherapy, um, there can be consideration for initiation of suppression for those who have a history of HSV. For suppression, here again, there's like a whole bunch of different regimens. I choose one. I choose valacyclovir, and you can, as per the WHO, you can use the same dosing regimen for pregnant and non-pregnant individuals. I'm also happy to share these slides, um, and I'll send them just after the talk to Sarush, so you don't need to be taking notes or anything like that if it's distracting from the presentation. But if you're happy taking notes, that's okay too. This chart, I guess, is a little bit old now. I haven't done a recent search to see if it's been updated, but when I initially put together this talk, I found this resource, which basically offers a price comparison of many, 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 many medications that we offer to patients. And so this particular table compares valacyclovir to famciclovir to acyclovir, and you can see that the cost per unit is actually most cost effective for valacyclovir. So that's what I offer to my patients. Something that I will occasionally offer, either if somebody doesn't want to be on a valacyclovir, or for somebody who I'm finding like full suppression is a challenge even on valacyclovir, occasionally I will offer lysine supplements. Now, this is of course paid out of pocket, and basically a 41-day supply if you order it on Amazon, and who knows who's going to be ordering off of Amazon if there's tariffs, whatever. Um, but if you purchase it, a typical container will last you about 41 days at the appropriate dosing. So you're looking at about, just under $20 a month if you're going to try to control HSV with lysine. It's very important that patients understand that you do need to get to the 3 gram a day dosing. And that's because studies have demonstrated that if you're using less than that, particularly if you're on less than 1 gram a day, it's not effective. And you do want to avoid lysine if somebody has cardiovascular disease or gallbladder disease. Okay, considerations during pregnancy. Um, so the highest risk situation when it comes to herpes and pregnancy is if somebody who is susceptible to herpes becomes infected with a primary infection during the third trimester. The reason why that is so high risk is because not only would that fetus be at risk of the primary complications of congenital syphilis, sorry, clearly congenital syphilis is on my mind all the time, congenital HSV, but also because the third trimester that offers less than 12 weeks before delivery, which means that the time it takes to mount an immune response and have antibodies present that can be shared with the infant, it's very reduced. It's contracted and likely there won't be a great serologic response that can be shared with the baby before birth. So that then the infant is also at risk of neonatal disease. So there's really kind of two big categories, although one of them has some subcategories of presentations. It's important to distinguish congenital HSV, so that's when the pregnant person becomes primarily infected, viremic, and then the virus passes through the placenta to infect the fetus. And that is the most profound type of infection with HSV during pregnancy that can lead to, it has a high incidence of stillbirth, high incidence of multi-organ failure, intrauterine growth restriction, microcephaly. There's very few with intact survival if true congenital HSV occurs during pregnancy. Neonatal HSV is when the infant is not infected transplacentally and does not have evidence of HSV infection um, as a fetus, but becomes infected at the time of delivery. And here again, we're really looking at a situation where they're exposed to the virus at the time of birth, they acquire the virus, and they didn't get any antibodies from their their pregnant parent because there just hadn't been enough time between the primary infection and time of delivery. So they're born without um, a, any antibodies to help protect them or stimulate an immune response. So this can kind of present in really three ways. Either there can be kind of isolated skin, eye, mouth involvement, which I don't want to diminish. That can still be very severe, but typically not systemic. It can also present as encephalitis or disseminated disease, which looks more like congenital syphilis and has a high mortality. So the big take home point here is that we really want to avoid somebody acquiring HSV during pregnancy, particularly in the third trimester. And that's where I'm asking a history about the partner. If there's potential in that relationship to be exposed to HSV, then I'm talking to the couple about how we mitigate that exposure. Um, if somebody has a history themselves of HSV that is recurrent, we typically initiate suppressive therapy around 36 weeks or earlier if you're anticipating preterm birth. We know that acyclovir and valacyclovir are well tolerated during pregnancy. There are some variable reports of transient neutropenia for the infant after exposure to valacyclovir and acyclovir, but there are no other reports of ill effects or birth defects, and certainly compared to the risk of acquiring neonatal HSV, transient neutropenia that's mild is considered to be is considered to be outweighed by the potential risk of neonatal HSV. If there is a recurrent lesion that's present at the time of delivery, the the risk of neonatal HSV is present but small. It's 2 to 5%. And the reason why it's so small is because along with exposure to the virus, the pregnant parent is also providing a wealth of antibodies that they transmit transplacentally, and the baby is born with some protection on board. The risk of a baby having neonatal HSV if the pregnant person was asymptomatic, but there is viral shedding, is much less, far less than 1%. In terms of mode of delivery, in the third trimester, if there's been a primary infection, then we're moving to C-section. if there is a recurrence at the time of delivery. So somebody's about to deliver an infant and there's either an experience of prodrome or there's pre-crusted lesions, the Canadian recommendations are for a C-section. The UK recommendations recommend kind of an individualized decision-making pattern, looking at how long somebody's going to be in labor for, how much the exposure is going to be. Is it going to be a 1 hour delivery or precipitous delivery, or is it going to be a um, long induction with lots of intrauterine manipulation, scalp clips, et cetera, prolonged rupture of membranes. And the UK recommends weighing that 2 to 5% risk of transmission compared to the risk of morbidity and harm from a C-section. If somebody is asymptomatic, then we're offering a vaginal delivery as long as there's no obstetric complications. And if somebody has PPROM, we don't believe that an HSV lesion should prompt expedited delivery, but we do recommend acyclovir until delivery. And we've published a local case report to demonstrate that even in weeks and weeks of prolonged rupture of membranes, it doesn't necessarily mean that there's ascent of the virus to the uterus. Okay, resistance to acyclovir is very uncommon. So for the immunocompetent population, um, the risk of resistance is very small. It's higher, just above 5% in the immunocompromised patients. And the resistance is due to just two different mutations. Um, and I won't get into them. I'm barely familiar with them. Sorry, I'm not a viral geneticist, but there's just two mutations that um, cause the resistance. And um, what's happening in order to diagnose it is that we have to um, get a viral culture, because then you can apply the antiviral to the viral colony and identify a resistant pattern, and then they can sequence it to identify the resistant mutation. We can offer alternate medications, topical foscarnet and cidofovir. Interestingly, you can still use acyclovir for suppression. And the reason being, it's because the what you're suppressing is you're trying to keep um, the virus that is still within the sensory root ganglion from expressing itself. Interestingly, that's been a dormant virus, so that hasn't replicated and allowed the generation or propagation of these mutations. And so you can still apply acyclovir, because the theory is that the viral cells or the viruses that have been dormant have not yet developed the resistance mutations, and so therefore the acyclovir is um, is effective for suppression and keeping the dormant virus from expressing itself. Ethical considerations. So, as I said, HSV is something that can generate a lot of angst and anxiety for patients. HSV is not a reportable condition in Manitoba, and it's important to respect patient confidentiality and to make sure that we're establishing a therapeutic relationship and really providing non-judgmental care. There, I find that helping patients to navigate a discussion about disclosure to their partner so that they can work together to minimize transmission from a seronegative to a seropositive partner. It can take lots of time and nuanced discussions and supportive discussions. Um, and it's important to talk about what we can do to prevent transmission, including being mindful of when not to expose oneself. So during a prodromal period or during a period where there are active lesions, or commonly I'll prescribe suppression in my clinic to help to empower the seropositive partner from to feel like they're doing something to minimize transmission to their partner. So I think that for the last little bit of this talk, what I did want to make sure that we're touching on are the things that can cause genital ulcers that are not herpes, especially syphilis, which we'll see, which we're seeing more commonly than historically. I think it's important for us to be thinking about non-HSV causes, but also some immune and dermatologic conditions. Sorry, I just saw a note in the chat here. Oh, so Kathy, great question. Kathy's asked, how long from initial exposure can someone develop HSV symptoms? Can it be dormant for years? The answer is yes. And so the initial incubation period is about 3 weeks. So if somebody is going to have a primary episode that's clinically evident, it's typically 3 weeks after exposure. Many people don't have a primary episode that they remember, and it can be dormant for years until there is a reason for immunosuppression or stress. And so, Maya, great question. How long from starting suppressive acyclovir until it's not transmittable? Well, it's not necessarily not transmittable at any point in time. How long it takes to cause the viral load to drop, I actually don't know the answer to that question, but I can definitely try to follow up with Sarush for studies about. I guess we would be looking there for studies for time to no detection of shedding. So I'll try to get back to you on that, Maya. And if somebody wants to get pregnant, the first thing that I make sure that they know is that you can absolutely get pregnant and have a healthy pregnancy if you have recurrent HSV. What our goal is to avoid any lesions at the time of delivery. And I let them know that we would typically start suppressive therapy at 36 weeks to try to avoid any active lesions at the time of delivery. Or if they're coming to me with a history of lots of recurrent lesions, I might talk to them about being on suppression for the whole pregnancy. Okay, so I'm keeping an eye on the chat. Don't worry, everybody. Um, Syphilis. So this is really what I want us to think of. If we're thinking of HSV, we should be thinking of syphilis. We're swabbing for HSV, cat of nose, we're going to be also swabbing for syphilis at the same time. This is typically a painless ulcer, and rather than a vesicle, rather than a cluster, it's usually a solitary lesion. It might be painful though. We have seen a surrounding cellulitis sometimes with a chancre. And so even though we think it's supposed to be painless, sometimes the surrounding cellulitis can make it painful. You'll want to both do the swab. You'll still want to send serologies though, because you're going to want to know what the titer was before you treat. Okay, chancroid. We don't see this as much in Manitoba. However, I think it's reasonable to at least know if you saw something that, you know, was multifocal, bilateral, it's an ulcer, um, but it doesn't look like syphilis. I think it's important to know at least how to diagnose it. You're going to take a swab and you're going to ask for a culture for Haemophilus ducreyi. You're probably going to want to call your microbiologist to make sure you're sending it on the right swab. It's going to get plated on the right medium. Oh, yeah, chat. Okay. Keep those questions coming, guys. I think what we'll do is we'll get through the non-HSV, and then I'm going to go back to those HSV questions. We'll get to everything. Okay. Okay, LGV. So here, rather than having an ulcer or vesicles, we're having more lymphedema, which is the central focus um, of the dermatologic changes. And here we're going to take an aspirate, and we can send it for chlamydia trachomatis testing, or if we're not able to get an aspirate, we can send for serologies for chlamydia trachomatis, serovars L1, L2, and L3. So those were infectious things that can kind of present as genital ulcers, genital vesicles sometimes, or genital swelling. The next three things are non-infectious things that can look like ulcers that we shouldn't ignore, even though they're not infectious. And the theme for all of these is biopsy, biopsy, biopsy. I'm not talking about the treatment here today. We're just talking about identification. So lichen planus, Behçet's, and Crohn's disease. Oh, sorry, I guess there's just the one slide. Lichen planus has that reddish appearance. It can look like an erosion over a wide space. Behçet's can present more like distinct ulcers, and Crohn's disease usually is kind of like an amorphous, asymmetrical, and sometimes a lesion spanning a larger area than you'd expect for something like HSV. For these, you want a biopsy. What we really don't want to miss is any intraepithelial neoplasm that might lead to vulvar cancer or vulvar cancer itself. Oftentimes, these can look more raised than ulcerative, but they present in a variety of ways. So if you see something that doesn't look like an ulcer, that's not responding like an ulcer, biopsy. I think that brings us to most of the end of the talk here. So the take-home points for me is have a low threshold to think about HSV and also a low threshold to think about syphilis. You want to take a swab and be aggressive about the swab because you really want to make sure that you're not going to come back with a false negative. You want to get to the base of the ulcer, de-roof the vesicle. Have a low threshold to treat recurrences, or again, this should say suppression. This deeply impacts people's quality of life, and I think they should be empowered to have treatment as much as they feel is needed for their quality of life. Serologic tests for HSV can be important in certain clinical scenarios, but broad screen type testing for HSV serology without a really good indication can actually do more harm than good. And if anything's not responding the way you'd expect, if anything looks atypical, think about non-HSV infections and send the appropriate testing, and also think about sending a biopsy to make sure that you're not missing any skin conditions, including cancer. I think that's that. So what I'm going to do is I'm going to open up the chat here. Okay, so Maya, I'm figuring out the time to no viral shedding once you start HSV suppression. Then we've talked about counseling a patient. Okay, so for the patient, how are they going to conceive? So the condom helps to reduce the risk of transmission from one person to another. It doesn't completely eliminate the risk. So it's important that they know that there is ongoing risk of transmission with use of a condom. They do have the option, as most couples where there is somebody that has HSV, they conceive through natural conception. And I would offer advice about avoiding having any intercourse if the seropositive person is having prodromal symptoms or active lesions. If there is additional concern, or if the tolerance of risk is very low, then the other thing you can offer is to put the person who has herpes on suppression while they're trying to conceive. And if they have ongoing concerns about risk, then I suppose you could always refer them to a fertility specialist to talk about methods of conception that would eliminate the need for sexual intercourse. Okay. Yes. So Kathy, the swab now, if you send it for syphilis, they're just going to send it for all three: syphilis, HSV, VZV. If you send it for HSV, they're going to send it for syphilis and VZV. So whichever one of those three you request on the requisition, they're just going to send it for all three of them because the epidemiology of syphilis is so high right now. And you can send it on one swab. One swab, you check off any of those things that you're looking for: HSV, VZV, or syphilis. They'll send it for all three, and you can use the swab in the viral detection medium. What do you use to take the aspirate? It's a great question. I mean, I think I'd be looking that up on UpToDate because I have not seen LGV myself. I would assume that you're using a fairly wide gauge needle, maybe like an 18 gauge needle, and you might have to use several attempts in order to get any specimen. Okay, interesting. Okay, so. You touched a tiny volume. You've barely seen the fluid, but you got a positive varicella PCR. Oh, so I'm just trying to understand your comment here, Pravina. So it seemed like a small amount of fluid, but they were able to get a PCR off of it. And if that's what you're meaning with your comment, that's not
Oh
surprising.
yeah, sorry, that was me.
Okay.
Um, I tried to take the aspirin myself because like the story didn't fit with the lesions, and it was an elderly guy who didn't have a good reason for having herpes. But yeah, I struggled to find the right tools, and I was just wondering if you used anything in particular to get aspirates.
No, I would just use what you have around, just like you're describing. If you wanted to, so in this case, it sounds like, so it was the fluid that was like in the barrel of the needle that you were able to get the PCR on.
Yeah, like it didn't even look like there was fluid in there, but I just like pushed the syringe down onto the swab and sent it, and it came back with a really clear result. So I guess it
Awesome,
worked.
awesome.
Yeah,
The
thanks.
the power of molecular diagnostics.
Yeah.
Okay, could you briefly go over the indications for swab if history and lesions are typical? Okay, Aisha, that's a great question. So if somebody comes to you and they're like, "Oh, I get these all the time. I've been told that I have HSV and I have the recurrence again." If everything is like looking typical and it's typical on history and they've had recurrences, I, you know, I think that you could argue to not necessarily diagnose it if they are going to kind of carry that diagnosis of HSV with them and they feel comfortable with that. I do think that if there are questions about whether they have HSV, most patients typically like to know if this is for sure it or not, and that would be an indication to send the swab. Um, but you're right that if it like walks like a duck and it quacks like a duck, you could probably hand them suppression and move forward without necessarily confirming the diagnosis. And if there's good response, then great, and certainly back to the drawing board if it's not responding the way that you expect it to. What is the likelihood of getting um, genital HSV from somebody with active lesions, and it can be in the range of about 25% to 50%. So it's fairly significant. And that, of course, is hard to test because we don't actually know the seroprevalence all the time in the population. So we don't know who's coming into that exposure, sero positive or seronegative. Okay, we're at the end of the questions. I think that we might be done just right on time. It's, oh, someone who doesn't, sure, pointers, Maya, pointers on a vulvar biopsy. You're asking all the great questions. And I'm going to see if I have some slides maybe that I can offer to Sarush with some pictures. But basically, you're going to want to think of it like any other skin biopsy that you do. You guys have your punch biopsies, 3 millimeters, 4 millimeters. You're going to infiltrate the area with local anesthetic. I'll typically use 1% xylocaine. You could use with epinephrine. And you are going to want to take potentially two biopsies. That's what I try to do. I try to take a biopsy at a point where the lesion looks the worst, and then at a point where there's interface with healthy skin and the lesion. And then the big thing that pathologists tend to talk to us about is avoiding like a crush injury. So rather than kind of doing your punch biopsy and then picking it up with small forceps, people talk about doing the punch biopsy and then elevating it with your needle, elevating it enough to cut the base of the biopsy so that you're not crushing the specimen before you put it in formalin. And I'll see if I can find some slides to send along to Sarush to talk a little bit more about the punch biopsy.
Sure. Yeah, please send to me and I will share with the other people.
Okay, sounds great.
Thank you for your time. Again, a great session. Much appreciated.
Yeah,
And
well, happy to be here. Thanks, everybody.
also thank you for your offer for having more sessions. So I will let you know. We'll be in touch.
Okay, that sounds great. Have a good
Thank you.
night.
Take
Bye
care.
now.
Bye.